So basically in the psychiatry, the first part here, it is like the assessment and all that, like history taking. And I think it is more important for the NACOSKI part. But for us, we have to know like what are the important tests that we are like doing for the assessment for the psychiatric patient. And this questionnaire, like screening the major psychiatric disorders. So these questions are important, like have you been feeling down, depressed, or hopelessness, anxious, low energy? So basically all these symptoms are present in one or other of the psychiatric disorders, right? So that is important in the history taking. And then this all is like the complete history, like present illness, all the social problems, treatments, functional inquiry, past history, substance use history. So then we will ask everything. And then psychiatric functional inquiry is the abbreviation is MOPS. So basically it is mood, other medical problems, anxiety, psychosis, and safety. So this is just the abbreviation. So these all sidebars are kind of important in psychiatry. And then this is like the detailed history if you want to read it. So past medical history, if the patient is taking any medications, because of those medications, maybe he's having those effects, past family history, medical history. And always we have to check about the abuse, if there is any abuse going on, and then all detailed history, developmental history, personal problems, and all those. So this is basically the first part is all the psychiatric history part. And then in the mental status exam, then we have to check like the mental status. So how we check that, the abbreviation is aseptic. A is for appearance and behavior, S is for speech, then emotion, that is mood and the affect, perception, thought, insight, and cognition. So all these things comes in mental status exam. So it is important to remember it because they can ask us like what are you checking in the mental status exam. So then the abbreviation is aseptic. And the MSE, that is the mental status exam, is analogous to physical exam. It focuses on current signs, affects behavior, and cognition. So that's why it is very important to do the mental status exam. And then the second thing, after appearance, we are checking the speech. So speech is also very important because in some of the psychiatric illness, one of the symptom is like speech, like in schizophrenia and some psychotic disorders. Some they are like very fast speech, some there are very slow or pressured. So that's why it is important to rule out like which kind of speech patient having. Then the third one is the mood and emotions, so all the emotional states and stability and all those stuff. Then the fourth thing is perception. So in the perception there is hallucination, illusion, depersonalization, derealization. So all these have to be ruled out. Like what are hallucinations? These are sensory perception in the absence of appropriate stimuli that is similar in quality to the true perception. So hallucinations, then illusion, misperception of real external stimulus, then depersonalization. What is depersonalization? Change in self-awareness, such as the person feels unreal distance, detached from their body and unable to feel emotion. So it is important to know like the kind of definitions if they are asking, so at least we know like what they are talking about. So depersonalization, as the term is saying, the patient is feeling like depersonalized, like detached from the body kind of. And derealization is feeling that the world outer environment is unreal. So they are thinking like the outer environment is unreal. And then there is poor correlation between clinical impression of suicide risk and frequency of attempts. So it is not like it is correlated. There is actually poor correlation. And what is the spectrum of effect? Like all the range from full restricted, blunted, flat, like what is the uh, like the behavior of the patient. And MSE is analogous to, so this one I have already read. So this is all the mental status examination. So this is the abbreviation and these are all the detailed version of those. So then the fifth thing was the this was thought content and process. So thought content is very important for all the psychiatric illness because it's like different kind of thought process. So what is goal directed? Clearly answer questions in a linear, organized, and logical fashion. So what you are asking the patient, they are giving you the direct question, that is direct answer, clear answers. But what is circumstantial? Speech that is indirect and delayed in reaching his goal. So if you are asking patient one thing, he's like giving you all the other random answer. So he reached to the goal, like he give you answer, but then in between he's like talking about all the other stuff not related to the question, but delay in reaching his goal, eventually comes back to the point. So that is basically the patient is like talking random other stuff, but eventually he comes to the point and at least he answer you. But what is tangential? Speech is oblique or irrelevant, does not come back to original point. So the you are asking patient one question, so he's giving you all random answers, but he's not eventually reaching to the answer. So basically these are the two that is the main difference between circumstantial and tangential, I think. And then what is loosening of associations? Illogical shifting between the topics, and flight of ideas, quickly skipping from one idea to another where the ideas are marginally connected. So he's having flight of ideas, like he's talking all the random thought like stuff. So, and then what is word salad? Jumble of words lacking meaning or logical coherence. So he's talking like all the random words that are not making any logic. So basically there these are all the random thought process, but there is like little difference between each. So what is cognitive assessment? Use MMSE to assess. So basically the how we will assess it, the first thing is orientation, if the patient is oriented to time and place. Second is memory, attention, language, and then gross screen for cognitive dysfunction. So the total score is out of 30. So this is basically their test that they are doing for the mini mental status examination. And what are the things that they are checking is orientation to time, place, and then memory, attention, and language. And then this is the scoring. If it is less than 26, then it is abnormal, and 20 to 26 is mild, and if it is 10 to 19, moderate, and less than 10 is very severe. So according to this, what points they are giving, and then the scoring system, if it is less than there, then it is very severe. So what is the key to differentiate between obsession and delusion? Is that obsessions are usually ego dystonic, meaning unwanted and not fitting in with a person's goal, and self-image, while delusions are ego syntonic. So that is the main difference between these two. So this is the all the thought process, and then the thought content. So it can be like different kind of thought, like major themes, suicidal ideation, obsession, magical thinking. So all these thought content are like present in different psychiatric illness. So we will go through each of these. So this is also like different kind of delusions, like persecutory delusions, trying to cause harm to you. Like there is one like false belief kind of, and the patient is thinking that is the real thing, but it can be like a reference. And then erotomania, belief that another is a person is in love with you. Grandiose, so they have special powers. Religious beliefs, so these are all the different kind of delusions. Somatic, believe that they have a physical disorder or defect. And nihilistic is belief that things do not exist, a sense that everything is not real. So these are different kind of delusions. So insight, judgment, cognition, so all these are included in the like on the psychiatric illness evaluation. So yeah, mental status examination, so all these are included in it. And then acknowledgement of symptoms as a departure from baseline or source of suffering. So this is all the assessment of judgment, insight. So everything is included in the mental examination. And then assessment and plan after the history taking and everything. Then the main criteria is the DSM-5. So basically we are following, I think, DSM-5 criteria. So they accordingly, like whatever symptoms and signs and duration is present, then we will check all the criteria is meeting or not. And this is important, always rule out the substance use and other medical causes before considering psychiatric illness. So basically this is one of the criteria in all the like the mental psychiatric disorders we will see. So we will check that. So now So this is the suicide is one of the key objective of MCC. So this is like kind of important for especially I think for CDM and all those parts. So in the suicide assessment, what basically we are checking, first we are asking patient about suicide will not give them the idea or incentive to die by suicide. So this is like kind of a false belief, like asking the patient. We have to directly ask the patient. So the best predictor of completed suicide is history of attempted suicide. So if there is any history of attempted suicide, then the um, that is the highest risk factor. The most common psychiatric disorders associated with complete suicide are mood disorders and alcohol use disorders. So these two are important ones because it results in completed suicides. So what are the main risk factors for the suicide? So this is important to remember because it can come in CDM. So the abbreviation is SAD persons. So SAD, S is for sex, that is it is more common in male. A, age more than 60 years, depression, and then P is for previous attempts. So that's we have seen the previous attempts is the highest risk factor. And then E is ethanol abuse, rational thinking, delusion, hallucinations. If there is any suicide in family, O is for organized plan, and N is for no spouse or no spousal support, and serious illness, intractable pain. So basically, sad persons. So if they are asking the risk factors or they have mentioned in the question stem, so we have to remember these risk factors so then we can identify the risk factors. So must be screened for every encounter, part of risk assessment along with violent homicidal ideation. So how we will approach the patient with the suicide ideation. So ask every patient, have you have any thought of wanting to harm or kill yourself? Classify ideation. Is this a passive or active? Passive is like death wish, where patient would rather not be alive but currently has no active plan. So this is important if he have the active plan or if he not have. If he have the active plan, then I would rather not wake up. I would not mind if a car hit me. So this is like active plan. And active ideation, I think about killing myself. So why it is important? Because these persons are more like risky, they can attempt it right away, but the passive ones they are not exactly making any plan. So then how to assess the risk is plan, do you have any plan so of ending your life? So you can ask this question directly. Intent, do you have, would actually carry this plan? If not, why not? So we have to explore what is the patient is actually thinking and in the intoxication and all those things. So assess the suicidal ideation. Onset and frequency of thoughts. When did this start or how often do you have these thoughts? Control over suicidal ideation. How do you cope when you have these thoughts? So basically we are assessing the patient's capacity or capability, the how he is like managing all these thoughts. And then intention. Do you want to end your life? Do you want to kill yourself? Intended lethally, do you think what would happen? SS2 means, so all these questions, provocative factors, what makes you feel worse, protective factors, what keep you alive, and then final arrangements, have you written a suicide note, make a will. So these questions are to judge the severity, like how this the patient is seriously thinking about the suicide. So just to explore the his thinking, and then I wonder if there is a part of you that wants to live, or all these questions. And then this is important, determine level of risk and develop treatment safety plan. So this safety plan and treatment. So this one is like important. So after checking the risk factors, um, we have to check if the patient is having like what is the safety plan or the treatment plan for that suicidal ideation patient. So assessment of suicide attempt, setting, isolated or other present, planned or this, substance abuse, medical inattention. So these are all the assessment. And as we have seen, it is like 20 to 1, 100 to 1 in younger patient, 4 to 1 in older patients. So this, and these are all the risk factors that we have seen here, like the sad persons. So all these are the age and male sex and ethnic background. Then there are psychiatric factors. Past suicidal attempt is the biggest one. Then all these psychiatric disorder are like make the patient more prone to at high risk, kind of the psychiatric factors, all these. And it is most common cause of death for age 15 to 24 years, so that is important. Like in younger age group, the most common cause of death is suicide, and rate of completion in person more than 75 years. So all these psychiatric factors, psychological factors, and all these psychiatric disorders and past history. So these all are the high risk factors. And what are the clinical features? Symptoms associated with the suicide is like hopelessness, anhedonia, insomnia, severe anxiety, impaired concentration, psychomotor agitation. So all these clinical features can be present. So what is the management of that patient? So the first thing is proper documentation of the clinical encounter, and rationale for management is essential. So the first thing is the documentation and what we have assessed about the patient. And then second is for high risk patient with a plan and intention to act severe, have access to lethal means. So if it is like a very risky patient, so then all the plan and intention to act if he have, then we have to. So for the risky patients, what we are doing, hospitalization should be strongly considered if the patient actually have like any active plan, or after assessment we come to know. So then we have to hospitalize the patient. Do not leave patient alone. Remove potentially dangerous objects from the room. And if the patient refuses to be hospitalized, complete form for involuntary admission, form 1. So this form 1 is important because this is the form that they do in hospitals if the patient, obviously the patient is suicidal, so he doesn't want to be admitted. So then the physician can admit him involuntarily after filling the form 1, and must give patient form 30 to notify them for their admission. In Ontario they are giving to form 30, but like the main one is form 1 that is used like all over Canada, and in Ontario basically form 30 they are giving to patient. So for lower risk patients, so for high risk it is strongly encouraged to admit the patient. Now for the lower risk, not actively suicidal with no active plans or access to lethal means, so discuss protective factors and supports in their life, remind them what they live for, and promote survival skills that help them through the previous suicidal attempts. Then this is important, make a safety plan, and then agreement as they will no harm themselves, avoid alcohols and all the risk factors we will try to avoid. And patients in whatever the condition they have, like if they have depression, consider hospitalization if symptoms severe or psychotic features present, otherwise outpatient treatment. And if they are substance abuse, suicidal usually resolves with abstinence for, so whatever their condition is. So basically if we resolve that one, then the suicidal ideation will be lessened. So patients with personality disorders, crisis intervention may or may not hospitalize depending on the patient's condition. And then patients with schizophrenia, hospitalization is may be necessary. And then this one, the long-term psychotherapy and all this. So basically this is like all about the suicide and how we will deal it.